So as of now, the traditional treatment for muscle-invasive bladder cancer, what we consider to be the gold standard, is neoadjuvant chemotherapy followed by radical cystectomy. Or as an alternative in very carefully selected patients, we're able to do trimodal therapy, which involves complete debulking of the tumor and then concurrent chemoradiation therapy. The problem really relates to the fact that a significant proportion of patients won't actually necessarily benefit from neoadjuvant chemotherapy. We know that there is actually very good level 1 data based on randomized phase 3 trials that have been published quite some time ago that really shows that neoadjuvant chemotherapy undoubtedly improves survival. So if we're kind of looking at the ballpark of improving survival in about the absolute risk reduction is about 9% at 5 years if you look at SWOG 8710. And what that particular trial showed us was that pathologic complete response, or PT0 rates, when we examine the cystectomy, is actually a really important marker for durable long-term survival. It should be viewed as a biomarker. And while we have many patients, roughly about 30 to 40% achieving this with chemotherapy, there's much to be desired. And obviously, with the current era of immune checkpoint inhibitors and their kind of effectiveness and activity in bladder cancer and urothelial carcinoma, obviously these agents have been taken up earlier in development, particularly into locally advanced first, and then into muscle-invasive bladder cancer, and actually, interestingly, into non-muscle invasive bladder cancer now. So, I'm happy to get into further details of how sasanlimab works and our rationale for radiation therapy. So I'm going to step back a little bit, and I've said that the problem is that we can get pathologic complete response in about 30 to 40% of patients with chemotherapy alone. And so, how do we do this, and why is this so important? Because the pathologic complete response is a really useful surrogate for us. It is very closely associated with long-term survival. And improving this has been a very important target because you improve patient survival, you potentially open up the window for bladder preservation. However, the issue is that a significant amount of patients are cisplatin ineligible. They cannot receive it for a variety of reasons, predominantly renal failure being the most important one. So really, when we look at how to move forward, I think there's 3 broad approaches. We have to widely adopt neoadjuvant chemotherapy, which at the community level hasn't been taken up to the levels that are ideal. There's a biomarker selected approach, which is let's identify patients that are most likely to respond to chemotherapy. For example, some folks have focused on DNA damage response genes, which we know respond, having mutations in DNA damage response genes may predispose a patient to better response to cisplatin-based chemotherapy, for example. And of course, there's the whole idea of now starting to regard bladder tumors based on their intrinsic subtype, and then personalizing the actual therapy. So those are kind of coming into the next kind of generation of trials, where we're kind of looking to identify patients that are most likely to respond to a particular regimen. But of course, there's novel regimens and combination of novel regimens that are coming out. And of course, the most important, I think, growth has been in the immune checkpoint inhibitors. So we've seen phase 2 trials come out looking at neoadjuvant immune checkpoint inhibition before cystectomy. We've seen multiple, at least 4 or 5 phase 2 trials looking at immune checkpoint inhibition together with gemcitabine and cisplatin as a combination, and also double immune checkpoint inhibition with the traditional PD-1 blockade plus a CTLA-4 blockade. And while this has been encouraging in terms of safety, and particularly being able to capture and help those patients that are cisplatin ineligible, I think the data is somewhat sobering. We're seeing really pathologic complete responses in the low 30s up to mid 40s for the doublet immune checkpoint inhibitors. And so, there's obviously much work to be done. And of course, these are all phase 2, and there's phase 3s that are concurrently going on. And the field is really thinking about, how do we move the needle forward? How do we achieve higher rates of immune pathologic complete response? And what are better combinations potentially? And so our group really thought about, how radiation comes into the fold. Radiation is immunogenic. It leads to, the release of antigens and uptake of these antigens by antigen-presenting cells. And these are very tumor-specific antigens. And so we really think that this is an opportunity to combine with immune checkpoint inhibitors. The immune checkpoint inhibitor that we proposed in our trial is a PD-1 inhibitor called sasanlimab. It's actually unique because it's a subcutaneous formulation. The overall phase 1 data really has supported its safety. And the adverse event profile of this drug is really consistent with, the same class of immune checkpoint inhibitors. And so the phase 1 data actually supported a phase 3 that's already been conducted, surprisingly, in the high-risk BCG naive non-muscle invasive bladder cancer space, which is looking to really combine immune checkpoint inhibition with BCG concurrently to see if we can get better responses in non-muscle invasive bladder cancer. These results, this trial is completed but hasn't read out. And so we elected to use sasanlimab based on the data that's out there and combine it with radiation. And we took a real deep dive into radiation therapy for bladder cancer. Of course, there's regimens for bladder preservation that are what we consider to be definitive radiation doses. And a lot of our rationale and background for how we selected our radiation dose comes from work that Dr. Sylvia Formenti, who's a radiation oncologist at Weill Cornell, has done. And, her group has really looked at what would be the optimal dose of radiation to be immunogenic. And it turns out that actually dose really matters. So when we, based on her preclinical and translational work, you can basically clearly break dose into two categories, one with high dose like 20 gray delivered to the tumor. What tends to happen down that pathway is actually there is double standard DNA breaks that are in the cytosol. However, what ends up happening is that those high doses ends up upregulating DNAs which clears the double standard breaks called TREX1, which is actually not going to be synergistic, which is not going to go down the pathway of activated dendritic cells and synergy with any sort of immune checkpoint inhibition. And so the preclinical work that really supported this was actually using a dose of radiation of 8 gray times 3, which goes down the pathway of allowing double stranded breaks to accumulate in the cells and going down the pathway of appropriate sting activation, which is known to lead to activated dendritic cells and synergy with CD8 T cells being primed. And so therefore it makes sense then to combine this sort of strategy with immune checkpoint inhibitors such as CTLA-4 or PD-1 blockade. And so thankfully we have some clinical data in the in other spaces, particularly in the non-small cell lung cancer, with data in heavily pretreated patients which are treated in the metastatic setting. And this is a unique study because you're treating sites of metastases with 8 gray by 3. This is in the context of CTLA-4 blockade and looking at the response rate in the other tumors. And actually, this went on to further work actually in the neoadjuvant setting for non-small cell lung cancer, combining durvalumab versus SBRT plus durvalumab, with very impressive major pathologic responses in the patients that received radiation plus the immune checkpoint inhibition before surgery. So this really motivated our rationale for study. We felt that the combination of stereotactic radiation at 8 × 10³ really as an immune stimulatory dose together with immune checkpoint inhibition would really work on the tumor immune interaction at various levels. Obviously, killing of cancer cells that releases antigens, leading down this pathway of dendritic cell priming, which would obviously drive the immune response. And, the activation of T cells is obviously very important, potentially seeing new antigens. And then obviously with the immune checkpoint inhibition coming in to uncouple the brakes on these potential newly activated effector T cells.